Let's join Dr. Lawrence Robbins for a discussion on unique geriatric pharmacological issues.
This is probably the most important slide right at the beginning, the first two slides. This just reminds you that the current population people over 65 represent about 12 to 13% of the population, and they consume a little over 30% of all prescription drugs. By 2040, the population over 65 will be in the neighborhood of 20%, and half of all prescriptions will be written for them. Here's an interesting article from the New England Journal back in 2012. An Italian group looked at patients involved in cardiovascular drug trials, that's the lighter gray or blue, approved from 2009 to 2012. And then they looked at patients who were actually treated with cardiovascular drugs in 2011. Here's what they found. 2/3, roughly, of all enrollees in clinical trials of cardiovascular drugs are under the age of 65. Yet, 40% of the prescriptions we write are for patients over 75. And in fact, only about 10% of all patients enrolled in clinical trials of cardiovascular drugs are over the age of 75. So we test drugs in younger folks, and then we prescribe them to older folks, hoping that that's okay to do. And I would simply say that that's not always the case. So we'll talk about important effects of age on pharmacokinetics and dynamics, recognize the risk factors for adverse drug events in older patients and ways to mitigate them, and some principles of prescribing for older folks. So which of the following pharmacokinetic factors changes least with advancing age? Absorption, distribution, metabolism, or elimination? Changes least with advancing age. Yeah, the correct answer is absorption. The surface area for absorption is huge, and so that really doesn't change much with advancing age. Now, what other drugs you take may affect absorption, and things like tube feeding can interfere with absorption of drugs. Classic one is dilantin and tube feeding, so it often interferes with absorption. But absorption itself, basic absorption of drugs, doesn't change with advancing age much. 80-year-old hypertensive woman has switched from atenolol to propranolol to treat her tremor. A week later, she seems more bradycardic, confused, and despondent. The most likely cause is that she's taken extra propranolol, decreased metabolism of propranolol, the lipophilia of propranolol, or reduced elimination of propranolol. Good. Most of you recognize lipophilia of propranolol, meaning that drugs that are lipophilic cross the blood-brain barrier better. That's why atenolol tends to have less CNS effects. It's not as lipophilic as propranolol, and arguably could be one of the reasons that propranolol seems to work with essential tremor, where the data for atenolol is not as convincing. The aging effects on volume of distribution. So we know that with advancing age, there's a tendency to dehydration, so total body water to drop. So volume of distribution for drugs that are water soluble drops, meaning that you get higher concentrations. Decreased lean body mass means a lower volume of distribution for drugs that bind to muscle. Increased fat stores means that lipophilic drugs hang around longer, disproportionately stored in older folks. Decreased plasma protein, particularly albumin as well as others, means a higher percentage of drug that will be unbound if they are normally protein bound. All of this leads to start low and go slow. An 84-year-old man has been less alert. His balance is deteriorating. He was taking 5 milligrams of Valium twice a day, diazepam, and agrees to stop. 1 week later, he's no better. 3 weeks later, he's improved. The most likely explanation is you withdrew the drug too quickly, active drug metabolites, increasing receptor sensitivity, or patient must have continued taking the diazepam without telling you. Okay, good. Most of you recognized that drugs like diazepam, older benzos, have much longer half-lives. The primary reason is they have active metabolites. When you look at the different ways in which the liver metabolizes drugs, there's phase 1 and phase 2. Phase 1 includes oxidation, cytochrome P450, And these can be reduced with advancing age. Phase 2, primarily conjugation, is usually less affected by age. What does that mean? That means that drugs that are dependent upon phase 1 tend to have more effect in older folks than younger folks, less metabolism of them, and cause more toxicity. They hang around longer, whereas those that depended on phase 2 are less likely to be a problem with advancing age, which is why it's said that you want to avoid things like diazepam or chlordiazepoxide Librium in older folks if you were using a benzo and use something like lorazepam, which is primarily phase 2. With that said, you shouldn't be prescribing benzos to any older patient. Okay. Changes in which of the following pharmacokinetic factors accounts for the most difference in drug effects with advancing age? Absorption, distribution, metabolism, or elimination, the most important pharmacokinetic factor with advancing age. Good. Since it's the only one we haven't talked about, it's elimination. Now, what do we mean here? Well, this is an important principle. Ask you the question, 50-year-old woman weighs 150 pounds, has serum creatinine at 2.2, so significant chronic kidney disease. There's an 80-year-old woman who weighs 110 pounds, her serum creatinine is 1.4. Just about the upper limits of normal, maybe slightly high. Which one is going to have more difficulty clearing drugs? And the answer is, if you do an estimated creatinine clearance without actually measuring 24-hour urine creatinine, what you find is, using something like the Cock-Gault equation, that the 50-year-old woman has an estimated glomerular filtration rate of 33 Cs per minute. The 80-year-old, 23 Cs per minute. Okay? So it's important to recognize that serum creatinine is not as good a predictor of renal function with advancing age, where lower body mass, decreased lean body mass tends to mean that there's less low creatinine clearance that needs to be done, and therefore it's not as serum creatinine is not as good an indicator of renal function. An 80-year-old on warfarin has an INR of 2.5. The best explanation for increased bleeding risk compared with a younger patient is difference in elimination, difference in metabolism, difference in volume of distribution, or pharmacodynamic differences, whatever that means. So an INR of 2.5, the patient is therapeutic. It's exactly where you want him to be. But she has an increased bleeding risk. Why? Well, pharmacokinetics is, if you will, is what the body does to the drug. Pharmacodynamics is what the drug does to the body. So in elderly folks are at increased risk, even at therapeutic appropriate doses of drugs, because of other things going on in them. So they're more likely to bleed because their stomach's more friable. They're more likely to have a subdural bleed because they're more likely to fall down. It doesn't have to do specifically with the pharmacokinetics of the drug. It's those pharmacodynamic issues. It's the patient in whom the drug is being prescribed. And the challenge, as we all face, is do the therapeutic benefits outweigh the potential risks, especially in older folks? So we'll talk about risk factors for adverse drug events and ways to mitigate them. The single greatest risk factor for adverse drug reactions in the elderly is the number of drugs we prescribe, period. Consistent finding in studies. More specifically, 6 or more chronic conditions, more likely to be on drugs. 12 or more doses and also have problems handling the drug. 12 or more doses of drugs daily, compliance becomes more suspect in that situation. 9 or more medications. To potential drug interactions, if you look at patients who take 2 drugs, there's about a 5 or 6% chance that there's at least a potential drug interaction. On 5 meds, that hits 50%. By the time you're on 8 meds, there's almost a 100% chance there's at least a theoretical drug interaction that could be significant. If you've had an adverse drug event to any drug in the past, it increases your risk of having more adverse drug events to some new drug you're being prescribed. Lower body weight or low BMI, age over 85, estimated creatinine clearance less than 50. All of these have been shown to be risk factors for drug toxicity. Mark Beers of blessed memory. Mark, many years ago, was part of a program to try to convince physicians that there are drugs that we really should be avoiding in the elderly. He created a comprehensive list. It's been revised and updated. There's now a 2015 version. It's available for free. If you go to the American Geriatrics Society website, you can find it under their publications. And it's a group of experts who get together every couple of years to reevaluate drugs that they think really should be avoided in older folks in most settings. And examples are all muscle relaxers, tricyclic antidepressants, benzodiazepines, etc. Other drugs to avoid: diphenhydramine, hydroxyzine, first-generation antihistamines, clonidine. Its central effects can cause confusion, dry mouth, dry eyes. Amiodarone, digoxin in doses above 0.125 daily, all benzos, glyburide, chlorpropamide, indomethacin, meperidine. The list is quite extensive. Prescription errors are made when one looks at the patients in an outpatient setting. 20% of ambulatory older adults receive at least one potentially inappropriate drug. One of the more common problems we see is about 20% of all patients getting Aricept are also prescribed an anticholinergic. Makes no sense. Taking a cholinergic drug and then you prescribe an anticholinergic. Nearly 4% of office visits and 10% of hospital admissions are either primarily or a significant contributor to the reason for that visit or hospitalization are medication effects. Then we have a different problem: appropriate medication but not being monitored correctly. So it's been estimated, for example, in various studies, anywhere from 10% to about 2/3 of all patients on ACE inhibitors who are elderly are not having their creatinine and potassium monitored on a regular basis, which should be at least annually. Preventable adverse drug effects. Most drug effects do not occur from improper choices of drugs or drug doses, but instead represent known side effects of drugs that have a rightful place in the therapeutic armamentarium. There's always that risk-benefit analysis that we should be doing. On Friday evening at 8 p.m., the answering service puts through a call from a 72-year-old man who's followed by a colleague. The patient's coughing and sneezing. In a nasal voice, he says, "Doc, I couldn't pee all afternoon and I just wet myself." Your next step is order an antibiotic for him to pick up at his local pharmacy. Tell him to sit when he urinates. Start an alpha blocker, or ask him about over-the-counter drug use. Yeah, ask him about over-the-counter use. Good. Okay, so why is this important? The elderly account for 13 to 15% of the population, but 40% or more of all over-the-counter purchases. Many won't consider this a medication, don't think to tell you about taking it because they figure, I get it without a prescription, it's not important. There are an increasing array, obviously, of over-the-counter medicines and drug interactions. And in this particular case, what do you take for a cold? You take an antihistamine, which is usually antimuscarinic, so it causes your bladder to relax. And it has an alpha-adrenergic like pseudoephedrine, which tightens your sphincter. And so you take a man who had symptoms of prostatism who can't urinate at all. So let's talk about some principles of prescribing for older patients. Ms. Manny Pills is an 80-year-old woman brought to your office by her daughter who moved her mother from Ohio 1 month ago and wants you to provide her primary care. Her mother had not been taking care of herself, quote unquote, and the daughter found her thin and disheveled during a recent visit. Patient has eaten poorly, lost weight, spends more time in bed. The daughter thinks her mother was treated for arthritis, asthma, anxiety, gout, constipation, and high blood pressure. She now wants refills of her drugs that she's been very careful to administer. Patient seems tired and her affect is flat. Her memory is impaired. Her blood pressure is 115/75, pulse 58. Mucous membranes are dry. She's photophobic. She cannot rise from a chair without assistance and walks with a shuffle. Her muscle tone seems increased. These are her medications that the daughter asked for: clonidine, theophylline, propranolol, verapamil, diazepam, furosemide, indomethacin, metoclopramide, amitriptyline, aspirin, carbidopa, levodopa, and 3 different laxatives. And the mother takes Tylenol PM to help her sleep. Okay, your next step: stop all medications immediately. Stop all medicines except dig and theophylline. Stop the medications, but taper down the clonidine and amitriptyline. Continue all meds, but cut the dose in half. See, I admire the people who put number 1. I really do. Correct answer for the boards is actually C, but I admire your courage. And the reason is there are a few drugs that we have to be careful about. Sudden cessation of medications, generally we get away with it, but there's some we have to be careful with. Amitriptyline is anticholinergic. So if you stop an anticholinergic suddenly, you can get so-called cholinergic rebound. They get borborygmi, they get hypervigilant, they may get profuse sweating. It can be very uncomfortable. sudden withdrawal of clonidine, everybody worries about rebound hypertension, right? The idea is you stop any hypertensive, blood pressure goes up. Well, this is where the blood pressure overshoots and can go really high. That turns out is very rare on patients who take less than 1 milligram of clonidine a day, which is a huge dose. But here we have a little old lady. She's taking 0.2, 3 times a day. Better part of valor would be to taper her more slowly. Again, with the amitriptyline, if somebody was on 25 or 50, you'd probably be able to stop that without too much worry about cholinergic rebound. But certainly doses that were higher than that, we'd be concerned and maybe consider tapering it. Remember that adverse drug effects can mimic diseases. So she gets bradycardic because she has dig, verapamil, and propranolol on board, all of which cause bradycardia. She was on 12 drugs, 12 or 13 drugs. She's got to have at least one significant drug interaction. Arguably, the most important one for her is the interaction of dig and verapamil. It turns out that if you take verapamil, it will double your serum dig level with some reliability. So dig dose should be cut in half if there's some reason to have the patient on both drugs. She has weight loss. Theophylline and digoxin cause nausea and make food taste bad, dysgeusia. Clonidine and amitriptyline cause dry mouth, make it harder to eat, and photophobia. Side effects begetting more polypharmacy. So the theophylline causes tremor. She gets put on propranolol. Verapamil, clonidine, and amitriptyline cause constipation. She's taking multiple laxatives. Verapamil, propranolol cause fluid retention, edema. She gets put on furosemide. Metoclopramide induces Parkinsonism. She's on Sinemet. Carbidopa, levodopa. Aspirin and theophylline exacerbating gastroesophageal reflux. She has to go on the antacids. So again, that's how it often gets worse. Digoxin, no longer a geriatric staple. The absence of left ventricular systolic dysfunction or atrial fibrillation with a rapid ventricular response at rest suggests dig could be stopped. Now, dig can slow heart rate with atrial fibrillation at rest. Not so good at slowing heart rate with exertion. If you have somebody whose heart rate goes up too fast, too high with exertion on atrial fib, generally better use a calcium blocker or a beta blocker rather than dig in that setting. All right. Which medications may contribute to her confusion and apathy? All the above. Good. Okay. Marvelous. Okay. So drugs that impair cognition, everything we prescribe except Colace and Tylenol. Okay? That's the simplest way to remember it. Most often it's psychoactive drugs and those with anticholinergic side effects. A promise I've made for 3 decades now. Discontinue the amitriptyline. If that's ever an answer on the boards, it's the right answer. Okay. Drugs impairing cognition. Literally, the list is ridiculous. It's anticholinergics. It's anticonvulsants, muscle relaxers, antiemetics, dig, clonidine, amantadine, amiodarone, benzos, antipsychotics. The list is quite long. You have to be skeptical. Now, Eric Larson and colleagues did some of the best work in this area. They looked at patients who had cognitive impairment. They evaluated them for reversible cause of the cognitive impairment, and drug side effects popped up as number 1, potential reversible dementia. And in 50% of the patients they thought might have cognitive impairment due to their drugs, they got better when they stopped the suspicious drug. It was often a single medication, not necessarily stopping 3 or 4. Patients with drug-induced cognitive impairment were 3 times more likely to fall. Remember, if you have one adverse drug effect, you're more likely to have others to that same medicine or other drugs. Most offending drugs taken for several years prior to diagnosis. You'll miss an opportunity if you say her confusion can't be due to her blank. She's been on it for 7 years. I promise you, if you're skeptical and pull them off of a suspicious med, you'll help more patients than you'll hurt. Again, the Choosing Wisely campaign. Don't prescribe a medication without conducting a thorough medication review. All right, so how do we go about reducing polypharmacy? And none of this is truly rocket science. This was actually a protocol that was devised and published in the Archives of Internal Medicine back in 2010. What's the evidence-based medicine for patients of this age and disability to be taking this medicine? You can almost stop there because there usually isn't much. Do benefits outweigh known possible adverse effects? If you think the benefit outweighs the risk, does the patient have adverse symptoms that may be drug-induced? Is there a better, safer drug? And if not, can you reduce the dose of the drug? 5 simple steps in thinking about drugs in the elderly. Okay, so this was an actual study where they applied these rules. They took patients with an average age of 83. 60% had 3 or more chronic diseases, the patients we see. The mean number of medications they were on was nearly 8. 60% had medications that were discontinued. The mean number eliminated was 5. So they got them from nearly 8 to below 3. 2% of the medicines were restarted. So rarely was something that was stopped did it have to be restarted. 17% of the patients turned out didn't stop the medicine. They didn't want to. 80% of the medicines were not restarted a year and a half later in follow-up. And 9 out of 10 patients reported that they felt they were doing a lot better after having this polypharmacy reduction. Let's talk about some principles of prescribing. The dangers of silo thinking, one size fits all, and time to benefit. Start you off with a case. An 81-year-old man with an EF of 30%, LV dysfunction, atrial fib and diabetes transfers primary care to you. He's got dyspnea on exertion with routine activities of daily living, so New York Heart Class 3. Medications include furosemide, lisinopril, digoxin, glipizide, warfarin, and long-acting beta blocker. So not a bad regimen. Hematocrit 38, K4.7, creatinine 2.1, sodium 135. And he tells you that his cardiologist recommended spironolactone. He says, oh my goodness, do I have to take another pill? And asks for your advice. So what are you going to tell him? You tell him, well, there was this landmark study back in 1999, the Rouse trial, showing that baby doses of spironolactone, 12.5 to 25 milligrams, it's nothing, combined with standard heart failure treatment, reduces morbidity and mortality. It was dramatic. And here's what the data was. The average enrollee in the trial was 65. What's the average age of heart failure patients in this country? LV dysfunction. Close to 80. Trial was stopped early at 2 years because interim analysis determined spironolactone was efficacious. It saved lives. Death rate fell from 46 to 35%. Number needed to treat 9 to save 1 life in 2 years. Nothing we do is that dramatic. Lower risk of death from progressive heart failure and sudden cardiac death, and symptoms were improved. Symptoms of heart failure were also improved. So add spironolactone to the drinking water of patients with advanced heart failure. Reduces both morbidity and death. Okay, so a group of Canadians 5 years later said, wow, what a breakthrough. We should see what impact this has in the real world. So they decided they would review spironolactone prescription rates in hospitalized patients over 65 who were taking an ACE inhibitor in Ontario before and after Rouse. Remember Rouse, 1999, so this is before and after. And what they found was that use of spironolactone in heart failure patients markedly increased after the publication of Rouse. The average age, though, was 78, 13 years older than the average patient in the Rouse trial. They found that there was also an increased risk of hospitalization for hyperkalemia in this group of patients after Rouse, with modest but significant increased risk of hospital death from hyperkalemia. Small, but statistically significant. They also found that there was no significant change in the gradual decline of hospital readmission for heart failure. So what had happened even before Rouse was the rate of readmission for heart failure was slowly going down in Ontario. And after the publication of Rouse, they didn't see a sudden drop-off. It just continued at that same slow rate. And some more skeptical viewers said there wasn't the impact we expected to see. So why? Well, the use increased dramatically after publication of Rouse without the anticipated benefit. Prescribing for patients, especially those with kidney disease, who would have been excluded from Rouse, was likely a major factor. In fact, if you go back and read the fine print on the Rouse trial, if you were 65 and your creatinine was 2.5 or above, you couldn't get into the Rouse trial because 20% of those patients in a preliminary trial developed severe, significant hyperkalemia. Now think about an 80-year-old. Again, 80-year-old who weighs less than the average patient in that trial. An equivalent creatinine may be as low as 1.5 that we should be using as a cutoff as opposed to 2.5. So this is silo thinking, failure to account for impact of multiple chronic diseases on treatment, efficacy, and safety. Why do we study 65-year-olds with heart failure? Because you got to find people that only have heart failure to figure out if the drug is going to work. And then what do? We take it to 80-year-olds with 6 other medical problems, and we assume that it's going to be just as effective and safe. And that's where we get into trouble. One size fits all. The HIVIT trial. Hypertension in very elderly. So up until 2008, when this was published, we had very little data on treating hypertension in older folks in terms of randomized trials. So this particular trial was designed to specifically answer the question, do we treat hypertension in people over 80? Couldn't get in if you were under 80 into the trial. And it confirmed that treating hypertension, cutoff was 160/90 in patients over 80, reduced all-cause mortality. And the conclusion of the editorial that followed was, HIVET puts the question of usefulness of treating hypertension in the elderly to rest and provides important guidance to physicians and writers of guidelines for treating hypertension. Well, here's what they didn't tell you about the HIVET trial. There was not a single patient from North America or from Western Europe. Most of them were from Eastern Europe, particularly Bulgaria and Asia. Over 75% of the patients were actually under 85. That was between 80 and 84. And these were very healthy octogenarians. In addition to that, it turns out that for folks in Asia, hypertension seems to have a greater risk of stroke at any given level than it does in the average person in North America. So the potential benefits were even greater in that population, and they were incredibly healthy octogenarians. Here's another report, because there's also this conflicting data that after the age of 80, high blood pressure might actually protect you from death. So why this weird conflict? Well, and by the way, if you haven't seen it, the SPRINT trial that was just published in this country was basically showing that people with an average age of even 70 and above, that there seemed to be a benefit in terms of reducing cardiovascular complications for treating them down to an average of trying to shoot for 120, they actually averaged 122, versus those that they were aiming just below 140 and they were in the upper 130s after treatment. And there was a benefit of even tighter control in this particular trial of treating older folks. But again, remarkably healthy patients. Well, this is a study that came out of the NHANES data. This is nearly 2,400 participants. These are community dwelling who volunteered to come in. They had their blood pressure taken 4 times. They threw out the first value, averaged the other 3. They also had them do a walking test. They had a van and they had them walk 20 feet. And what they found, they said, walk at your usual pace. And they basically divided them into fast walkers, that is, patients who could walk more than 0.8 meters per second. That's about 2.5 miles an hour. And then they had the slow walkers, or the non-walkers, people that for whatever reason couldn't walk at all. Well, it turned out if you were a fast walker, if you could walk at least 0.8 meters per second, there was a 35% increased risk of mortality if you had systolic hypertension over the next several years of follow-up. However, in the slow walkers, there was no correlation between your systolic blood pressure and your risk of mortality over the next several years. And in fact, if you couldn't walk for whatever reason, the higher your systolic blood pressure, the better your mortality. So we see this paradox of frailty and hypertension and not really fully understanding how we determine who we have to treat most aggressively. Certainly healthy elderly, there's no argument. Frail older folks, data may be less clear. Time to benefit. Here's a 75-year-old with diabetes, advanced neovascular macular degeneration, which is independent of diabetes, mild heart failure, hypertension, Parkinsonism, and renal insufficiency, returns for follow-up. You note that he hasn't had a hemoglobin A1C in a couple of years. The last was 9.2, and his blood pressure remains greater than 140 over 90. All right, so for type 2 diabetics, time to benefit of tight control to prevent eye and renal microvascular complications may be decades before you see that benefit. Now, in younger type 1s, within 10 years, the risk of diabetic retinopathy can be considerable. We want to be as aggressive as we can, but type 2s, not so much. There's little evidence that tight control reduces macrovascular disease. You know, that data is very controversial. Coronary disease, risk of stroke. Okay. We also know from the ACCORD trial, published in the New England Journal in 2008, that patients with an average age of 62, those who had tighter control, trying to get their A1C down to below 7, they were average 6.4, versus those with looser control, A1C of 7.5. After 3.5 years, there was actually increased mortality in the tightly controlled patients with no cardiovascular benefit in those at the higher level. We also know that hypoglycemia resulting in need for emergency room visit is associated with an increased risk of developing dementia. And the more episodes you have, the more likely you are to develop dementia. So the Choosing Wisely campaign concludes avoiding using medications other than metformin to achieve hemoglobin A1Cs of less than 7.5 in most older adults. Moderate control is generally better. In fact, if you think about the role of ACE inhibitors in diabetics, the time to see a benefit in slowing the progression of renal disease if they have renal insufficiency may be as little as a year, where there's a divergence between those who got an ACE inhibitor and those who got placebo. So one could argue that in this elderly patient living alone with limited mobility, poor vision, obviously goal number one is we are not going to risk hypoglycemia at any cost. That can be fatal. And it may be that tight control is not as important as perhaps putting him on ACE inhibitor, which will help both his blood pressure as well as his renal function in a life expectancy that this patient has. So practical management of elderly folks with multiple chronic diseases. Choose treatments that have clinical impact with the life expectancy of the patient, the fewest adverse effects. Choose treatments that may have benefit for more than one disease. So we want to avoid polypharmacy. Beware of changes in compliance contributing to new drug toxicity. Parsimony applies to treatment, not just differential diagnosis. And don't assume what's good for a younger patient or otherwise healthy elderly with one disease is good for older patients with multiple diseases. Thank you for your time.